I am Rishi Manchanda. My mom wrote that bio. Let me try to earn some cred just directly by telling you a bit more about myself so you can tell me whether I can stay in this room with you. I am a social medicine trained physician. Paul Farmer was a mentor of mine, and many in Massachusetts know that name. And in many ways, the experiences I have had as a clinician, whether it's in South Central Los Angeles, building clinics and providing care to veterans experiencing homelessness, or building programs and clinics for farm workers in the Central Valley of California, all of that really started because of one of my experiences here. For about 12 years, I lived in the greater Boston area for school, lived in various communities, including Somerville and Cambridge. In so many ways, this is coming back to a place that was a formative home for me. And that's part of the reason I'm both sharing my professional kind of background to see if I could earn some street cred to talk with you guys here, but also to let you know that this is for me very personally meaningful and professionally meaningful because of the formative role that this community has played in my life in many ways, including some of the mentors I met along the way. It was also here about 2 years ago, my father, who had been experiencing cognitive decline and dementia over about 5 years, finally passed away after experiencing some significant, being diagnosed with stage 4 lung cancer as a non-smoker, very surprising thing. It was in that moment of years of being a caregiver, not just as a professional trained clinician, but as a family caregiver, which is a much harder task, as you can all attest to. It was here actually in the Boston area where my mother and father spent some of their time, and in Los Angeles where we live, where they split their time. It was in both these communities where I learned really firsthand about the need for health and social care integration to take place for the reasons that we're talking about here: health, equity, and independence. But it was also fundamentally important here in that experience to understand where there was incredible quality of care on the healthcare side. There was things we could access on some of the social services that we needed. And we also identified opportunities. And this is why, as Acting Secretary Lifson just mentioned, the opportunities, as you're doing here in Massachusetts, to identify ways to improve culturally specific and culturally relevant kind of care, right? To be able to connect to the lay organizations out there, including the Indian community that kind of came together and supported our family through this. There's so much, there's so many resources we ended up stumbling into and finding that there was so much goodwill and so many people who had been in the same shoes that we'd been that were just waiting to kind of pay it forward, waiting to kind of help out somebody else. In other words, the goodwill that we discovered as a family helped tide us through an incredibly difficult kind of time in our family's life. And it underscored for me what an age-friendly community kind of means, which is really to be part of a thriving community where everybody, those who are aging and everybody else, really benefits. So for that reason, may I stop with my spiel here and say, may I hang with you? Can I stay here in this room? Have I earned some cred? If you said no, you're going to have to pull me off the stage because I'm actually excited to be here. So I'm going to be here anyway. So I wanted to speak today about promise, peril, and opportunity, this moment that we're in, and share some insights because of the experience I've had both as a clinician, but also through this organization called Health Begins, which I'll tell you about. I think this is the way to advance the slide. Do I do? Let me see. I click right. Is that right? Should I use the mouse? I can advance on the. That's great. Thank you so much. All right. Thank you. Appreciate that. Lovely. Okay. So I think this will allow me to go forward here. Okay, excellent. Okay. Thank you. We're good?
Now we're good.
We're good. Oh, now we're good here. Now we're good. Okay. Oh, excellent. Good. Okay. So I won't tell you more about Health Begins because you'll you've heard a little bit in the bio, but the main point is this is an organization I've had the privilege of being a part of with an incredible group of colleagues, and it's afforded us the opportunity to meet a lot of folks across the country who are working at the intersection of health and social care, those who are trying to bridge these two sectors so that we can improve outcomes for everybody, especially for people in communities who are most vulnerable to societal harms, right? So that's where I'm drawing a lot of my experience from. And I think as I share some slides and get into some storytelling today and try to make some room for some questions and answers and maybe some Rotten Tomatoes, I really want to just put 3 questions in front of us today that I want us to revisit in the bottom half of my talk. The first is, how do we sustain this work going forward when it comes to health and social care partnerships? The second is, how do we sustain our partnerships? And the third is, how do we drive impact for patients, for people in communities who need help the most, including those among the aging population. To give us some context here, I'm going to share this. This is something from a report called Mirror Mirror that was released just a few weeks ago by the Commonwealth Fund, an organization that does a lot of work, policy research, kind of grant-making organization that does a lot of work in the healthcare space, as you're maybe familiar with. And this report, called Mirror Mirror, compares US health outcomes to peer nations, Australia, Canada, France, et cetera. And as is perhaps not surprising to anybody here, we've seen a steady increase from 1980 all the way for the past 40 plus years, a steady increase in the percentage of our spending as a country on healthcare. Not news to anybody here, right? Increase, uptick. What's notable is actually that in 1980, we were not that divergent from our peers. So it is within our lifetimes, right, that we've seen this trend accelerate, this spending accelerate. And of course, we know that as healthcare spending has increased, that has not come with the commensurate benefits that you would hope out of an investment of dollars, which is perhaps improvements in health outcomes. You can see the US on the bottom right here in terms of where the US ranks overall in health system performance compared to peer nations as well. So we're spending a lot and not getting a lot out of it on healthcare spending. And one might argue, especially for folks in this room, this might resonate. Part of the reason, of course, that we know this is the case is because the amount of money we're spending in healthcare is not adequately being spent on the things that we know shape health. The conditions in terms of where we live, work, eat, sleep, and play, all the services that are here, because we're not investing, relatively speaking, in the social sector right now, we are seeing perhaps this outcome right now. So the reason that the healthcare spending line doesn't correlate with health outcomes is in part because we're spending so much on health care rather than on social care. Right? So this is the situation just a few weeks ago, this came out. And so in that context, this macro context, let me try to bring it home by sharing a story. We heard about Sam recently. I'm going to share another story to try to ground myself and us in this conversation today about as we answer those key questions. This is a story of Mrs. M. Mrs. M is in her mid-70s. She loves her 2 now adult children, her adorable granddaughter, and her adult children live in a different state. So she sees them, but not often. She has a fixed income. She spends quite a bit of money on out-of-pocket costs for healthcare. She also happens to have type 2 diabetes and some advanced chronic kidney disease as well, requiring medications and close follow-up with healthcare providers. Anyway, at the end of the last month, she nearly passed out. She does some work or volunteer work on the side, and she nearly passed out. And so she was rushed by the paramedics to the hospital, and the diagnosis that the doctors and nurses came back into to Mrs. M with after a day of hospitalization was clinically significant hypoglycemia. In other words, low blood sugar. And so she asked the question of her caregivers that I'll ask to you, which is why? Why is she experiencing this? How did she get to this space? And in the traditional healthcare setting, you would expect and want there to be an evaluation of biological causes. Was there some sort of infection that dysregulated her blood sugar metabolism? Was there some underlying tumor that's leading to an overproduction of insulin? There's all sorts of important things biologically we need to evaluate and look for. But we know that after evaluating for all that the most likely culprit here, the most likely cause, the answer that we give to Mrs. M is food and nutrition insecurity. We know, of course, that in Mrs. M's case, and much for many individuals like her, food insecurity itself, which is a household level phenomenon, right, that talks about limited or uncertain access to adequate food, is a way that many of us who are in the caregiving, whether in healthcare or social services, the way we think about this, the USDA definition. We know that many are advocating for moving past some of the limitations of food security to talking about nutrition security, right? To say it's not just about access to calories, it's about the quality of those calories as well, and making sure that the food is affordable, healthy, so that the foods can actually prevent and sometimes even treat disease. Food is medicine kind of work. We know this is happening, and part of the thing that I think is interesting in these conversations that we're part of, both in the state that with colleagues here that I've spoken to, as well as in other parts of the country, is that while we're talking about food and nutrition insecurity, and maybe we talk about Mrs. M or Sam or other patients, we often don't reframe that as a story of harm. We'll talk about statistical differences between populations and macro policy kind of implications, but we don't talk about the harm. And we know that from that perspective, Mrs. M is like, unfortunately, many Americans who are having higher rates of harm. She's being admitted to the hospital along with other folks like her at a higher rate. You can see the statistics, the stats there. Cross-sectional analyses show that food insecurity is associated with a higher risk of actually having chronic kidney disease. The research tells us that food insecurity is associated with the progression of chronic kidney disease to end-stage renal disease. I'm getting really clinical now, and I'll come up for air. But it also is clear from the research that this food insecurity, this harm itself, this social consequence of structural kind of harms, is itself a predictor of mortality. Just the food insecurity, and partly because of the way it's impacting her biological, the way it's getting into her body, right? The way it's literally impacting her health and harming her. So I want to share this story right now and the associated statistics really to kind of say from a lot of the folks in the healthcare space who are now talking about upstream social needs, social determinants of health these days, which is a big sea change compared to 10 years ago. The question about partnership, aligning health and social care, we can proceed on this using Mrs. M as a story in mind. So I'm going to now talk about in this moment what is at risk and also how far we've come when it comes to Mrs. M and the story of what we can do together to improve outcomes for her. And my premise here is that we are at an inflection point. This is the bottom line up front kind of slide. We're at an inflection point in our journey upstream towards health equity. There's a lot to celebrate. There's a lot of promise, a lot of progress really that's been made in the last several years, especially in centering equity and in pursuing health and social care integration. We shouldn't forget this. We should celebrate this. This is progress that is hard fought and has been recent. And I will go through some examples of some of the progress that we've made. But there's also a moment of peril, and I'll speak more about some of the risks that we experience, including the risk of underachieving, right, on the promise of integration, and end with kind of opportunity, which is, as we work to try to integrate health and social care, I think we can and perhaps should reimagine the ways in which we partner to demonstrate value and I'm bolding the word here, to reallocate power and resources. I'll come back to that. You with me so far? Let's talk about the promise. I'm going to go through this at a pretty fast clip because I want to get to the peril, bad news leads. So let's celebrate, but not too much because let's get to There is a lot to celebrate though. If we look in the last few years, at the national level, at the federal government, there is now a playbook to address social determinants of health. This playbook did not exist until recently. The U.S. Department of Health and Human Services has now created calls to action around how to address social needs and social determinants of health. So at the federal level right now, we're seeing far more emphasis and explicit focus right now on social needs and social determinants. Again, 10 years ago, did not exist. We're seeing many different concrete examples. This is acronym city, so don't worry about all the words. The point is that when the federal government's acronyms start to speak about social determinants of health, there's been a shift. So for example, in Medicaid and Medicare services, we're seeing now opportunities and levers that we're pushing on to be able to address social needs, whether it's through 1115 waivers and demonstrations, the use of in lieu of services. In Medicare, there's a variety of different opportunities here. All of you are experts in many of these, especially looking at the latest physician fee schedule and the various codes. Some of you are experts, especially on this work right now. on being able to think about the new codes that can be used to be able to help affect the diagnosis and the treatment of unmet social needs. Similarly, for ACL, of course, and other federal agencies right now, like the CDC, we're seeing now more grants and more programs and supports, more NOFOs and RFPs, all the things of federal grant making right now starting to give a nod to, if not explicitly mention, the need to screen for, if not help address social needs. And that goes for the tech side of things as well, the ways we share data. This is huge. Just to double click on this a bit more, we're seeing advances in the standards by which we actually describe, we integrate social care into healthcare. So in our quality measures, whether it's the NCQA HEDIS measures or CMS value-based payment models, in the regulations that we see and some of the standards that are out there, including the accreditation bodies for healthcare, like the Joint Commission, the NCQA. If you're getting that kind of eyes glazed feeling, that's the point. There's so much happening. There is so much happening right now in terms of policy right now addressing this. It's hard to keep track of now. And again, all in the last 10 years, right? There are efforts now underway to, that a lot of progress in terms of identifying the data standards, the ways in which we capture and code and share data when it comes to social needs of individuals like Mrs. M. The Gravity Project, some of you may have heard of the Gravity Project, a multi-sector collaborative project with hundreds and thousands in some cases of participants involved in helping to define the standards by which we define data on social needs and the interventions to address them as well. This data, these standards, as wonky as it is, are the living language that allows then for integration to happen for health and social care. So there's even been progress in this. So these use cases, initially from the Gravity Project for defining data standards, were developed first for some pretty basic use cases, like let's develop data standards for screening and for risk assessment and how to set goals and even data standards for how to capture data on interventions. Straightforward things. In a process that's unfolded just in the past year with support from our organization, Health Begins, working with the Gravity Project and several others like Civitas, if you know these groups, we help facilitate a process to bring in social care providers, social sector organizations, including AAAs, to help review and update the use cases. And what emerged was a whole more sophisticated set just recently about the very standard. Just in the past year, the data standards have had a leapfrog event. So we're going to see these use cases now that are too many to list start to now make its way into the data infrastructure that allows for, again, communication around between healthcare and social care to improve. There's been a drumbeat now of work, including being able to define this interventions, what that looks like. These codes, these data, are things that are also informing what we look at in Medicaid, which is a sector a lot of my work focuses in on. And we're seeing across the country now state Medicaid agencies, as we know, there's so much variety across the country in terms of what different states do vis-a-vis Medicaid. We're seeing red and blue states, right, now start to include social needs screening and other interventions into Medicaid policy, into procurement contracts of Medicaid managed care organizations. We're seeing a commensurate focus on healthcare equity to make sure that we're identifying people who are not getting the same level of access or treatment or outcomes. This is huge, and this is linked, at least as we see it, to the social needs and social care integration question. So you can see here many more states, at least a quarter of states as of a couple of years ago, based on a survey run by Kaiser Family Foundation, a quarter of states reported at least one financial incentive tied to a health equity-related goal. And that's been increasing. So that's increased even in the last 2 years, and we're going to continue to see that. The point is there's increases in the regulatory spaces, and then part, we're also seeing increases in the advances in the evidence base. The evidence of the impact of health and social care integration, the evidence of the impact of addressing social needs. Here in Massachusetts, about 1.5 years ago, in the New England Journal of Medicine, there was an article that provided some preliminary evidence that showed that hospitals in Massachusetts with more robust social determinants of health programs had higher patient experience scores and lower mortality rates. Lower mortality rates. It doesn't get more concrete as an outcome than that, right? This is evidence that didn't exist several years ago, even though there was common sense understanding of this work. And the evidence continues to pile up. There is an evidence review guide that is on our site. The Commonwealth Fund, our partners, worked on developing this. And now we have published studies that look at various different outcomes, including costs of care and financial kind of data on each of the interventions that are out there, including case management, medically tailored meals, and other services. For Mrs. M, for example, there's more research now than ever about the impact of food as medicine interventions, including those at the top of the pyramid for those who are at the highest level of need, like Mrs. M, those who have complex care needs, which of course AAAs and ASAPs are experts in addressing. And we see a variety of now evidence coming to bear on what these nutrition interventions, including food as medicine interventions, can demonstrate. I'm going quickly because the drumbeat here is that a lot has happened in a short amount of time because of years and years of work beforehand, behind the scenes, to get us to this point. This has been a movement. And I mean that not just a social movement, but I mean a movement in policy, a movement, a shift in what the norms are of what we expect healthcare to kind of look like. And that shift has fundamentally been about understanding that we need to address social needs and there needs to be integration, health and social care integration. And clearly that has implications, and it's manifest through what we're seeing now across the country through what AAAs are doing when it comes to contracting with healthcare. This is a map from a national survey that many of you perhaps are participated in, led by US Aging and the Aging Disability Institute right now in 2023, that shows those states where you have AAAs, the majority of AAAs involved in contracting or not involved, and you can see the yellow or the orange, whatever that color is, that shows no known activity. The gray, the dark gray, shows no AAAs doing kind of contracting in this way or not involved. And then you can see the different colors, especially darker blue, showing where there's a lot of contracting kind of happening. And you're seeing now more and more states now having AAAs involved in healthcare contracting. In fact, that same study showed us that a growing percentage of AAAs, many of whom, of course, are here. You guys are at the vanguard of this in Massachusetts, are contracting with healthcare entities and are contracting through networks, which is something I want to come back to as well, because this is, I think, a powerful lever to be able to really unlock the potential to advance health and social care integration and to center power in AAAs rather than center power, frankly, in healthcare. I'll come back to that point. Because the main thing I want to land on here before I talk about peril is that there's a lot that has happened. And it's happened because of the growing awareness from inside of healthcare about what happens outside of healthcare traditionally, and the critical role that AAAs, ASAPs, and others who are experts in the upstream kind of spaces play in this work. This is a lot to celebrate. And I tell this story particularly not just with you, but in a lot of audiences, especially of healthcare providers, because for a lot of folks in healthcare who are in this moment right now, we don't realize how far we've come and how far we still have to go. And when we don't realize how far we've come and recognize the value that it brings with it, we can't see ourselves as part of a story. Us in healthcare, we can't see ourselves as part of a story that is partnered with social care. So it's important to share the story of promise, as I'm trying to do now. Does this resonate with everybody? Have you seen this as well in the past 10 years as well? Has there been a shift? Am I misreading this? There is a moment here, and it doesn't happen all that often. Certainly, in my professional career, this is a moment that is unique compared to 10 years ago, 20 years ago, and 30 years ago. And yes, I was doing work 30 years ago. So let's talk about peril, the risk. There are some challenges here, and there are many operational and tactical challenges, but I want to kind of zoom out and look at some of this from a perspective that looks at just the question of integration. And I think that and particularly when it comes to some of the challenges hiding within that promise, some of the sand traps, the pitfalls that are kind of hiding just behind view, and I think are more apparent to AAAs and ASAPs than perhaps to those within healthcare. So for example, one major risk right now is that we continue to do what has been done before, which is to fail to center equity in social needs interventions, in the way we do integration work, and thereby perpetuate inequities. Another risk is that we may not be able to capture and measure and build kind of value of this work because of a fixation on short-term ROI kind of needs in ways that might sacrifice our ability to define and capture long-term benefits. Where the healthcare kind of ROI analyses sometimes can undermine the ability to unlock the value, the dollars, the investments that are needed to actually support this work in a meaningful way. I'm seeing some head nods. Hopefully I'm earning my keep. Good. And last but not least, I think without equitable social sector partnerships and integration, healthcare-led equity in social needs interventions may perpetuate the structural inequities that exist between healthcare and social care. Thereby, and also limit accountability to the people who matter most, and undermine the collective capacity to improve health. I'll come back to that. Does that resonate? All right. Let's talk about failing to center equity for a moment. Just looking at the social needs kind of literature, and this is it's a representation in some ways. There's a lag, right, between what the published literature always shows and what is actually happening in practice, as we know. But there is something that's important to take away from the published literature. In a study published about a year and a half ago, a review of all of the published literature on social needs interventions, there was an analysis to see whether racial health equity in particular was mentioned or evaluated or assessed in the research on social needs interventions, including research on medically tailored meals, on intensive case management, on housing, transportation. And what they found was that, here's the punchline at the bottom, only 4 of 152 studies were conceptually thoughtful about what race or ethnicity means. We are totally still kind of catching up with the understanding of racism and race as a social construct in healthcare research, and I think in society as a whole. And that is showing in giant kind of glaring neon lights right now with like, if I could bring in my animation with me, you would see like all sorts of like, just underscoring that point. And this is something that we have to learn about, like, because when we don't center equity in our evaluation, let alone in our implementation, we end up perpetuating inequity. And let me give you another example. Researchers looked at the rise of various value-based payment models and models that have come out of CMS, specifically the Centers for Medicaid Medicare Innovation, CMMI. And they looked at value-based payment models over the past 10 years. Researchers at Harvard, just down the road. And they looked at the ways in which those payment models actually evaluated for and improved equity, meaning differences between subpopulations. And what they found was, in many of the cases, even the most vanguard models of value-based payment didn't move the needle, and in some cases, inadvertently perpetuated inequities, racial inequities. This is the vanguard of our payment models in healthcare. And the vanguard payment models didn't improve equity. And the conclusion of those researchers is, if you don't center equity into the policy design, into the implementation, into the work, then it is not some neutral kind of space that you land back on, right? It is not as if there's some sort of benevolent space where everything just happens to work out. Inequity results. When equity is not centered, inequity results or is perpetuated. And inequity is harm. So we are doing harm by not centering equity. That's a risk that we continue to face in this moment right now. And there's been progress. There's been some progress to be sure, but we have a ways to go. Let me talk about the other kind of risk about the value and ROI kind of conundrum. We know, of course, the importance more now than ever, especially when it comes to contracting with healthcare, to demonstrate the ROI, right, to calculate the financial impacts. At least ROI for the healthcare provider, which is a lot of the questions that end up being asked, right, of healthcare to the CBO. I'm not sure how many times that ROI analysis is just like, what's the value to you, like to a AAA? But certainly more and more, right, we've heard of and have been part of conversations, especially through some learning collaboratives we've run on equity with US Aging, that AAAs are finding a lot of questions about ROI are being defined by the ROI for the healthcare kind of provider and saying, okay, how do we calculate this? And that's important. I'll come to some tools that can help address that. But I want to name some of the risks, which is that ROI often lacks, first of all, an equity analysis. In other words, what is the cost of inequity? How do you actually quantify the cost of inaction on inequity? We can actually do that, but in ROI analyses, you don't often hear that being asked. And I think there's an opportunity, in fact, a responsibility at this point, if you're ever computing any ROI for anything, to be able to ask, what is the cost, not just of the assets and the resources, but what is the monetary cost that our community and our staff are paying for not addressing this inequity. ROI analyses often fail to include a racial equity analysis or equity analysis in general. That's one limitation of the method. There's another one, which is there's an asymmetry in ROI thinking and power. Healthcare is rife with low-value care. Anybody ever been to a healthcare provider? A hospital? We know there's been movements to reduce low-value care, right? Like unnecessary tests and costly procedures, et cetera, that could have been avoided. Healthcare is rife with low-value care and has been trying to move towards reducing that and improve the value of care. But healthcare is, as an industry, rife with low-value care. We just have to look back at that initial set of slides about the spending on healthcare and the value of health to understand that. So there's low-value care everywhere, and yet ROI conversations, in our experience, often comes up in nearly all discussions about health and social care integration, and not so much about like what's happening within the walls of the clinic, right? To put it this way, how many times have AAAs or ASAPs or community members said to the hospital, what's the ROI for that? For what you're doing? You see the asymmetry here? I'm asking that honestly. Like, how many times has there been a conversation, a conference where we're in a methodology to say, what's the ROI, what's the social return and the economic benefit and the health benefits of that healthcare entity right now? Show that to me while I also work in my math to show you our ROI. You see the asymmetry here? It's so baked into the norms right now, this structural inequity right now, that even that hypothetical feels absurd. But it tells us that there's an asymmetry in terms of how we apply ROI thinking and how often it comes up in healthcare. And lastly, there's challenges in terms of expanding ROI because the analysis, the methods don't often capture the value of social service investments that often aren't just about reducing utilization or improving certain revenue tied to utilization in healthcare. In other words, there's a lot more value that Mrs. M can get from a AAA than what oftentimes an ROI calculation can actually demonstrate. So that's a challenge. A couple of other challenges here. There's a lack of accountability, certainly as well. I'm speaking of now of the healthcare kind of sector as a healthcare provider, in one who's been involved in delivering care and being part of systems. There's a lot of good that we do, and there's a lot of necessity to what we do, of course. But there's still not enough accountability to local stakeholders, including patients and populations and places that are most impacted by societal harms. Let me give you an example. FQHCs, as you all know, federally qualified health centers, are a rare exception when it comes to community accountability. We know that 51% of a board in FQHC has to be comprised of community members. That requirement, as we know, doesn't exist for other healthcare kind of systems, especially now as more and more market consolidation has been happening, right? In healthcare, large systems, we see now boards of healthcare systems being comprised of folks who have a lot of expertise in private equity, venture capital, and certain finance. Not to say those things may not be important, but they're certainly not the only domain of expertise that may be relevant to whether a hospital or a health plan or a healthcare system can be relevant. Am I speaking out of turn? So in other words, this lack of accountability is not baked into the structure of many of our healthcare entities with the exception of FQHCs, and that actually is problematic, right? Not because there aren't people of goodwill in healthcare, but because people of goodwill can still work in bad systems, right? That end up unintentionally perpetuating harm. There's also lack of accountability to make sure that we're reinvesting in the upstream capacity and the interventions in the places where harms are concentrated. How are we diverting dollars, whether it's community benefits dollars or community reinvestment dollars? Where is the money going to in terms of the communities that need it most and to those who serve those communities? Are we asking for kind of money on the margins or is there real money going towards this? To illustrate that point, a review of health systems investments in social determinants of health for a period of time between 2017, 18, and 19 revealed that health systems in the US publicly committed $2.5 billion towards addressing social determinants of health. $2.5 billion, that's a lot of money, right? It is. But that figure is dwarfed by health systems' overall community benefit spending, estimated to be over $60 billion a year, most of which, of course, is writing off bad debt or Medicaid, uncompensated care. This is money on the margins for healthcare. So while I certainly am an upstreamist, and I'll tell you more about what that means, I'm a healthcare provider championing the integration of health and social care from the healthcare side, we know that healthcare is still underinvesting, right, in this work. And that's because of lack of accountability, especially to challenge this last part, to challenge policies, inequitable policies that accumulate structural advantages for some institutions and communities rather than for those that don't. I'm going to come back to that in a second. What that means is, are we in the service of accumulating capital for certain institutions, right? Demonstrating return on investments for some institutions, right, rather than others. This is an underlying kind of challenge that worries me in this moment right now because of these risks. I hope I'm not alone or speaking out of turn. One of the things that is also a risk, and I'm almost done with the doom and gloom part. We're going to get to what we can do in a second. Another risk here, and please let me know if this is resonating. Is this so far any kind of, I might do a Phil Donahue and kind of come into the audience. Is this working? So far, so good? I'm looking for the hook. Just let me know, Marta, when it's like. One of the other things, of course, that we know is that there are risks right now we're seeing play out when it comes to this really vanguard work that's happening, whether it's between AAAs and healthcare entities or other social sector organizations like food service providers or housing providers, including, of course, what AAAs and ASAPs do. We're seeing a lot of integration, which is welcome and incredibly important work, but there's also this kind of challenges that people have written about and talked about, which is bridges to nowhere, right? Without equitable reallocation of resources to the social sector, a fragmented, underfunded social service system may not be equipped to meet the growing demand from healthcare. Healthcare might be screening more for food insecurity among Mrs. M and patients like her and wanting to refer out. But if they're not sending the resources to support those services, well, then you end up seeing what's happening now, which is a lot of healthcare institutions building their own social service networks, right? Rather than buying it or partnering to do that. And that has real policy implications and real equity implications. There's also the wrong pocket problem, which has often been talked about, especially from health economists, which is that the benefits, we're seeing the accumulation of benefits to healthcare without necessarily the same commensurate kind of focus on sharing the benefits or requirements to reinvest those benefits into the social sector or public health sector. So as we're seeing benefits accumulate of health and social care, are the benefits now being shared equally or equitably? And lastly, the extractive practices part of it. Obviously, with the news of Stewart and what's happened in the state right now, this is not something I need to speak about at length over here right now, but we know that in the past 40 years with that graph of 1980 to 2023, we know there's been a rise not just in healthcare spending, but perhaps not surprisingly, a parallel rise in market consolidation and in extractive practices also in healthcare, including profiteering, debt collection that's been very aggressive, and other extractive processes, which not only contribute to poverty, inequality, and dispossession, but as political scientists have talked about, they also depend on them. In other words, extractive practices depend on poverty, right? It depends on this kind of reaccumulation. And we've seen too many examples, unfortunately, of those extractive practices right now invade and metastasize, I use that word intentionally, within healthcare. I'm looking for anybody who's going to tackle me now. It's like, and I say this with love, because, right? I say this with love because this is a sector I'm a part of right now, right? These are problems we have to kind of challenge, and this is particularly important. This lack of accountability, this lack of investing is something that actually has a fundamental risk here, not just to kind of sharing of resources between healthcare and social care, but because it actually undermines the health of our communities. Let me show you a study from 10 years ago to make this point. Researchers looked at something called community social capital. To illustrate what I mean here, you know about social connection, obviously. You guys are experts in being able to provide social connection to address those individuals who are experiencing social isolation, right? We know that social connection for individuals is vital to health. It also turns out that social connection, social capital between institutions is vital for the health of a community. Researchers call this community system capital or community social capital. And what the researchers here did was to take some measures of the connectivity, the density of relationships between organizations in different sectors, like healthcare, public health, and social sector organizations. And they measured that density county by county across the US. And what they found was that that density, as you can see, based on proportions of activities and kind of conversations and relationships between healthcare and social care and other sectors, that density of relationships contributes to population health activities, and more to the point, in counties that actually had more social capital between institutions, you had lower death rates. the connective tissue between healthcare and social care is not just about improving the efficiency of services, right? And the equity of who gets access to services. It's literally about the life or the death of a community. Community social capital is what you're building here. And when we think about health and social care integration, if the majority of resources, if the majority of how we're designing interventions to address social needs are done in a way that unintentionally accrues benefits to the healthcare sector at the expense of social sector organizations, we might be undermining the health of our community in the process. We might be undermining community social capital. Does that make sense? From a policy perspective, from an implementation perspective, this is a real conundrum right now that we have to kind of face right now, and that's why I come to this moment of opportunity, finally. All right, here's where I see some opportunities here. Now let's answer those questions before I get the hook. How do we sustain this work? How do we deepen our partnerships between health and social care? How do we address these risks and do so in a way that drives impact for Mrs. M and people like her? Meaning our loved ones, our neighbors, our relatives. First, I think when it comes to how do we sustain this work, I think we have to do two things. First, understand these issues as harm, and the second is to assess the returns and the value and the impact of this work. These are just two offerings right now for conversation. For example, when I shared the story of Mrs. M, I mentioned that Mrs. M experienced that hospitalization, and that was linked to food and nutrition insecurity. In our work, we consistently try to make sure that people understand these inequities, this question of social needs, really as manifestations of harm. That when people experience an unmet social need, when people experience a health outcome that has been driven by that unmet social need, that is not just an inequity, that is harm. And harm is something that all of us, whether we're in the healthcare side or the social sector side, can understand and relate to in our hearts and our minds. Harm is something that we're in the business of preventing and reducing. And conversely, healing is what we can then talk about as a way to counteract that. If I'm talking about inequities and not talking about harm and healing, then am I really telling the story that I need to tell to be able to build bridges between health and social care? I think this is where the power of story becomes important. Let me tell you another quick story here to give an example. Sometimes we can share patient stories or client stories, Mrs. M, Sam. Sometimes we can share parables. Here's a parable. There are three friends who come to the edge of a river. It's a beautiful day, sunny day. They want a picnic. One of them just got off work from the healthcare sector. Another friend just got off work from a AAA. Another person just got off work from a housing agency department. Can I get volunteers, actually? Can I get somebody in the front of the room just to raise your hand? No interactive exercises, just a hand raise. I've seen your name. That's all I need. Just you're volunteering. I'm quite literal. There's somebody, this is my Donahue style thing. Somebody from this table just want to raise your hand and tell me your name? Yes, sir. Sean? Sean, thank you. Can I get somebody in the middle of the room? See, that was painless, right? Sean did that? Kim? Yeah. Kim? Yep, good to see you, Kim. And then someone towards the back of the room, that last table over there. Clara, thank you. Now you can come up and do a dance. I'm just kidding. Sean, Kim, and Clara. Imagine it's the three of you guys who are now at this river. And much to your dismay, and much to everybody else who's now witnessing what's happening for you, we see people in the water and they're drowning. It's a really fast tide. There's a waterfall here. You know, the water from the mountains is coming down fast and leading to a waterfall. Sean says, I'm a really strong swimmer. I'm going to find out how to help those who are closest to the waterfall, those at most peril, and rescue them one by one, right? Which makes a lot of sense. We applaud what you're doing, right? We applaud what he's doing. We applaud what he's doing. This is good. Sean, in other words, Sean is rescuing people, which is a vital, necessary kind of role in this moment right now. Kim sees something along the banks of the river, like some twine, some branches, and says, wait, I can craft together a raft. I can maybe save, for every one person that Sean is saving, I can save 20 people. I can usher them to safety, right? This is now Kim's work, and she's ushering people to safety along the banks of the river. Also worthy of applause and also worthy of investments. Worthy of investments, worthy of applause, certainly. Now, over time, Sean and Kim realize something. Sometimes the very people that you just saved yesterday are back in the water today, right? And you guys don't get jaded or cynical about this, but in other rivers, in other parts of the country, your peers sometimes say things to people in the water like, you again? Like, didn't someone teach you how to swim? Right? They burn out. They start looking for other rivers to kind of swim in. right? But you guys remain committed to the work. You remain committed to being in the service of the people who are in need there. And over time, though, you realize, wait a second, Clara was with us on this picnic that went awry here. Whereas Clara, and they look further upstream and they see Clara now in the water, saving people as she's going, but she's swimming upstream, much further upstream than where our two friends are. And they shout to her, where are you going, Clara? There are people here to save. Won't you do that, Kim, Sean? Like say, there you go. This is not choreographed beforehand. That was wonderful. Kim, I owe you. And Clara says, I know, I'm going to find out who or what is throwing these people in the water. In healthcare, the common story of healthcare is the specialty providers, right? We also see this in social services, right? The specialty providers, those who have specialty kind of services for those at most risk, those at most peril, the rescuers. We know in healthcare it's primary care, and there's equivalent models as well for preventative kind of holistic case management and services for those at risk of going further downstream. That's primary care. And we have the story of the specialists and the primary care folks. But in healthcare, as I found in my experience, the story was incomplete. I wanted to fashion myself as a primary care clinician, as someone who's working in the health system, to be able to move upstream, to be like Clara, right? To be an upstreamist. I share this parable both to kind of illustrate my story over here, but to illustrate the power of stories to reimagine what we're thinking about. Another kind of way of thinking about this to use is to rework adages. You guys know this story? What if I told you it was wrong? An upstream analysis, a health justice analysis, an integrated health and social care kind of analysis allows us to start reimagining, and we must reimagine not just the experiences of the people we serve as harm, but of understanding our role in addressing that harm. And story is a way of reimagining, rejiggering expectations, and sometimes tired, rote kind of ways of thinking about what's possible and what's not possible. We need a fundamental shift, and we're going to always need this to kind of shift how we think about this work and how we communicate it. At the very least because it helps us to break down walls between healthcare and social care, but also because that can align us in the common pursuit of health and of justice and of opportunity. Parables, adages, Sam, Mrs. M, story is something that you guys obviously are very effective at telling, not just to funders in your annual reports, but in the work of integrating health and social care. And as we do that, we can then rally to address the social and structural drivers of this kind of work, the things that actually put people in harm's way. So instead of saying, oh, it's because we didn't teach Mrs. M to fish that she's in harm's way, it's because there was not enough fish in the first place or the pond was polluted or something like that. We can address the social and structural drivers of that way. And so, for example, just thinking about Mrs. M, food and nutrition insecurity, we know that she experienced food and nutrition insecurity, but we know that's shaped by the presence of food swamps and food deserts. We know that's also, of course, shaped even further upstream by power, by policy, by segregation, which is adjudicated who has access to resources and opportunities, and as some scholars and advocates in the food community talk about food justice or food injustice. We need to become more skilled at conversing with each other between health and social care at the social and structural causes of the harm, and be able to then talk about how we can each play roles in addressing that. One way to doing that, another way of thinking about this conceptually, is thinking about, for Mrs. M, she had was experiencing food and nutrition insecurity. And that's there because of food deserts, right? Or food swamps, where there's a lot of caloric food, just nutrient poor. Or, and there's also food redlining. The reason that there's no healthy, affordable food is because of policy choices. The question then becomes, as we integrate our work, can we move beyond just integrating services for Mrs. M, but start to identify patterns of harm that need to be addressed through system or even ecosystem level work as well? That's integration in that way. So as I move in the interest of time here, I think I have about 10 minutes. 5 minutes? 3 minutes? Am I way over minutes? Courtney's like done with me. She's like, 6 minutes? Okay, 6 minutes left. You guys ready? Home stretch? How you feeling? That was a lie. You're all tired. But I appreciate you hanging with me. Let's talk about value for a second, and then I'll round us out. How can we define the value? So as we think about this kind of new story and this new kind of understanding of the upstream kind of drivers of this, we can start to think about new ways to define value. And I know this is especially important now as we think about the work that AAAs across the country, including Massachusetts, are doing. We know that you're doing a lot of complex care, and the contracting work, as the surveys are showing across the nation, show us that AAAs are caring for a variety of folks, especially those at most risk. Those at high risk of hospitalization, at risk for nursing home placement, dual eligibles, of course those with chronic illnesses, including those with dementia and not with dementia. You're caring for the most vulnerable in our societies, in our communities. And what the survey that I'm referencing here also shows, of course, something that many AAAs are experiencing when it comes to demonstrating the value of that, of the many challenges that AAAs in this national survey reported. The top two were challenges in contracting related to negotiating price or contract terms, and lack of awareness by the healthcare entities of the very value and the services that CBOs provide. Does this resonate in this room? And again, Massachusetts, I think ICU, especially what I've learned in recent weeks, is you're far ahead of the curve compared to a lot of other states, as you know. And I imagine that some of these challenges still remain true, right? So then this is especially important when we think about social needs, because as researchers have now kind of looked across the value propositions, there are a lot of different value propositions for identifying and addressing unmet needs for healthcare. Some of these are because of, we now know in healthcare that there's a lot of ways in which identifying and addressing an unmet social need can either connect people to social services to decrease their social risk, and that improves health, to connect people with navigators to improve emotional support, to improve health, to connect people with outpatient healthcare services, like things that you can actually, you're doing a lot of connecting on behalf of healthcare back to healthcare appropriately, right, in your work, and that can improve health and avoid unnecessary utilization. And you're also improving, of course, self-management. These are the different pathways by which now social needs work, social risk is demonstrating value. The problem is that value may not be captured in the contracting and pricing process. Is that fair? So here are some free tools that have come about just in the past couple of years. Our organization, Health Begins, has partnered with the Commonwealth Fund and the SCAN Foundation, you know about the SCAN Foundation, sure, to develop a free online tool that was developed with input from a variety of community-based organizations, including AAAs across the country. This ROI calculator to address social needs allows us to be able to facilitate the process by which CBOs, AAAs included, can pencil out the potential value and demonstrate that value to a healthcare partner. In particular, I'll demonstrate how this new version of the tool that we just updated this past year is helpful because it pre-populates data from public data sets for things that sometimes AAAs don't have access to, which is utilization rates or cost data for healthcare. So instead of having to scramble to find it and then not getting out of the gates, here's a free tool that pre-populates data from the healthcare side to be able to calculate that. Let me give an example for like Mrs. M. Let's imagine that there was a AAA that's providing medically tailored meals. Anybody here do that? Yes is, I think, the answer, right? There's a lot of AAAs who are, and ASAPs who are doing this. So let's imagine that you wanted to quickly, within 15 minutes, assess the return on investment for your work. You're a CBO that provides MTMs. Let's say you're looking to serve 250 people. You can adjust the figures. You can pick the payer type, say Medicaid, identify the duration of that, let's say 6 months in this use case, and you identify the fixed costs that it costs for you to provide this, and you also estimate the administrative overhead you want to charge, 10%, et cetera. So you put the inputs in, which is what the calculator allows you to capture, and then you go through a process of using pre-populated data to be able to then come out with, within 15 minutes, a summary of financial returns. In this case, using the kind of inputs and the pre-populated data from healthcare data sets that are out there, this CBO can estimate that it looks like we might be able to provide a total PMPM benefit reduction in cost of $639 to the healthcare organization. And when we then account for the cost of providing the service to the CBO as well as to the healthcare organization, that nets out at $413, which is 183% ROI. These numbers may not be exactly relevant for you, of course, this is just hypothetical, but the fact that in this amount of time I was able to communicate to you a potential ROI means that now I have your attention about ROI, right, and the value. We realize these tools can become really, like, we need to provide these tools to more quickly be able to put something out there to say, hey, this is my set of assumptions, this is the ROI, what do you think? We also know, though, as I mentioned, that ROI analyses can be limited and limiting. And so I've talked about these earlier. It's time to start to update the methods we use financially. We've been working with economists and actuaries to start to push the needle on what it means to calculate the financial, the economic, and the social impact of work for MTMs or medically tailored meals or other case management services or others. And so, for example, we need to expand past just ROI methods to what folks call VOI or even social return on investment methods. Some of you are familiar with using this, perhaps. But these methods are actually financial methods or tools to be able to help estimate, for example, the value of something that doesn't have a direct financial return, like a savings and utilization, but has a real value. So if you're improving patient satisfaction or you're improving patient engagement rates for a healthcare partner, what's the value of that? How do you assign monetary value to that? These methods can help us do that, and this is a busy slide here, but this is a screenshot of a new report that summarizes now the ability to communicate financial returns, economic value, and social impact using these new methods for a given intervention. In this case, this was an intervention for a maternal health intervention, but the tool now can be used for these interventions as well. In other words, we have the opportunity to be able to demonstrate financial returns, economic value, and social impact to be able to really make sure that we demonstrate the value of our work. That's, I think, an important element of being able to drive integration, I hope. And of course, as we do this, we need to make sure that community, from the healthcare side, that community partners have a voice in defining value, not just mathematically, but being at the table to say this is valuable, that caregivers need to have a voice in defining value, and of course, community residents and patients like Mrs. M need to define that value. Because I'm short on time, I'm going to focus in on these next two in a briefer way than I wanted to. We can also deepen our partnerships by now moving from just basic coordination and really using a shared system of assessing how far along we are in our integration partnership. In other words, to assess our dating relationships. Are we kind of in the first date? Are we at second date? Like, are we getting ready to get married? Like, where are we in this, right? We developed, inspired by a framework that SAMHSA had put out around integration of primary care and behavioral health care about 10 years ago. We developed about 6 years ago a framework to help us define the levels of integration for healthcare and social care providers. And to show it to you instead of telling you about it, we defined, with input from a lot of stakeholders, level 1 dating, which is just basic coordination, level 2, which is, minimal coordination, then basic coordination, basic collaboration, where there's a lot more sharing of systems and communication between healthcare and social care, moving to collaboration and a little bit of integration, like using a shared system, set of shared systems, and even sharing data back with each other more, to basic integration, to then more full or robust integration as well. It's less important, there's a lot of words over here right now on the screen, but the takeaway is that we need some way, if we're going to assess how to deepen our partnership, to assess our partnership and to think about where we're going on that. This is a framework to help. And it's not the only framework that's out there, but it's a framework to start to help assess. I'm working with a healthcare partner. How deep is our partnership? Are we at level 2? Do you want to take it to level 3? We need to kind of use this to be able to assess how far and fast we want to move together in relationship. And sometimes it's okay to stay at level 2 because you don't want to get too close to respect your own autonomy and whatnot. But that's an important, right? It's an assessment tool that helps with this. Last but not least, I'm going to skip past this. We need to move from programs to actually portfolios. There are ways to think through this, and there are tools that are out there. But one fundamental kind of point is that there are far too many point solutions and programs out right now that are looking at social needs. We need to start moving towards a portfolio that says, how are we moving across different levels to be able to achieve impact for Mrs. M? So what are we doing at the program level? This is a tool called the Compass for Health Equity Transformation that identifies goals at the program level, which is this smaller one, at the system level, activities there, opportunities at the ecosystem level to increase the connection between our institutions, and goals at the societal level to actually shape the policies in the first place. We have to get past just working at integration of services, which is of course necessary and the right focus, but if it's the only focus, then we end up missing opportunity to bear witness to the system failures that our patients manifest every day in their lives, and miss the opportunity to integrate our abilities to do something about it more upstream. This allows us to create a portfolio in our partnerships rather than just a set of agreements around particular service. I'm finally there at the end. You've made it. Congratulations. This moment is a unique moment. It's a leapfrog moment, I think. And it's a moment that is on our shoulders right now. It's the thing that we now inherit right now from all the work that's been done in generations past. All the work you've been doing for decades, many of you have been at this for decades of work right now. This, for me, feels like a leapfrog kind of moment. A moment right now, as Baldwin said, to make the world that we're living in over again. This is what's happening. And to also remember that in case folks say, well, that's not, when that cynicism, that jaded kind of approach comes out, which of course we know where it comes from, we get it, I'm tired sometimes too. To remember though that this is not going to happen in some point in the future, right? This is, as Baldwin reminds us, about now. That salvation that we want from Mrs. M, that kind of hope that we want, that age-friendly community that's really about thriving that we want, is really about what we do at this moment. And I do see AAAs and ASAPs and the work that each of you are doing in this state really as vanguards. So I'll continue to be looking at what you're doing, and not only to find ways to support, as all of us are doing, but to really to look at ways to get inspired, because what you're doing is just that. I thank you. I wish you well with the rest of the day. I'll be mingling in the background, so if you have any kind of Rotten Tomatoes or notes for me, feel free to save it for direct contact. But thank you. I think we're done.